but I'm going to switch gears and talk about stress urinary incontinence and treatments that we can offer from the office to the OR. So I'm from University of Miami, and we started our unique urogynecology and urology-based joint fellowship a couple years ago that we're very proud of. Happy to be here. I have no disclosures pertaining to this talk. So these guidelines came out in 2017, defining SUI as involuntary leakage of urine with effort or exertion. Astonishingly, 50% of all women experience SUI symptoms, and lifetime risk of surgery for stress urinary incontinence is 13.6%. So when a patient comes to your office, it's important to really assess severity or bother, and a validated questionnaire can be used to assess that, and perform a physical exam. We want to demonstrate stress urinary incontinence on pelvic exam, and it's important to assess the PVR at baseline before doing any potentially obstructive treatment options. So for non-surgical treatments, we'll talk about all these things, and this is a Cochrane review looking at formalized pelvic floor muscle training with a specialized pelvic floor physical therapist, and women that underwent PFMT were 8 times more likely to report cure for stress urinary incontinence and 5 times more likely to report cure for any type of urinary incontinence. So I send pretty much all my patients to pelvic floor physical therapy with the referral for everyone. And just to give you an idea, the reduction of leakage is just 1 episode for stress urinary incontinence and 1 episode per day of all types of urinary incontinence. So again, it's really important to assess patient goals when they're talking about their leakage and the severity when you're talking about treatment options. So Poison Pressa is a vaginal insert that we can use that's over the counter that they can buy. It's 3 different sizes, and this compresses the distal vagina, coaps the urethra, can be used in younger patients when you're going to go for certain exercises or things like that. Incontinence pessary is also a space-occupying pessary that can be used as well, but I tend to use this less now that we have other great office procedures. And that we'll talk about invasive procedures that we can offer and go over the data for this. So historically, urethral bulking agents were macroplastique and coaptite, but now we are in the era of Bulkamid, which is a non-degradable polyacrylamide hydrogel, which I'll be focusing on for this talk. And this is performed endoscopically with a needle. So I talk, my fast talk with patients. It's just with a needle, no stitches. It's a 5-minute procedure, and you're going back 2 centimeters from the bladder neck, and very superficially placing this gel into the urethra to make it tighter, essentially. You're making the urethra tighter and coapting the urethra. A Cochrane review from 2017, so it's important to note the date of this, looked at 14 trials, and this was really looking at the older types of products that are on the market, and they concluded that there is insufficient evidence to guide practice and showed that the placebo saline injection was similar in results and lower success rates compared to sling. However, the U.S. FDA approved Bulkamid in 2020. It has been approved in Europe since 2006, and that's because particularly in the UK, mesh slings are still banned because of an all transvaginal mesh ban as well. So Bulkamid is safe, it's reversible, so you can just put a large bore catheter in for up to 2 weeks. It actually really molds over a 2-week time period, and it's a great first step option for patients. It can be done in the office. It can be done under local anesthesia or just with IV sedation in your ambulatory surgical center. So it's important to think about reimbursement. Our hospital in South Miami, we get more reimbursement at a hospital-based facility compared to a clinic-based facility. So it's just a conversation you need to bring up with your institution. So we have 7-year data to look at efficacy and safety of this product, looking at 1,200 patients, mostly from Europe, obviously. And this shows 80% of patients experience a significant improvement of stress urinary incontinence. Of note, 43% of patients required a second injection. We call this a top-up. And this is done within 1 to 2 months for optimal results. I think of Bulkamid like a cosmetic procedure. And so again, it's just with a needle, very easy recovery. It's really for my younger patients that want to get back to the gym. I live in South Miami, and so I look at that, and they do appreciate this as an option. Complications are low, so I counsel patients that they will have a different urinary stream after this procedure. It'll be slower. It'll take more time to empty the bladder, and urinary tract infections are at 3.5%. I personally give all patients prophylactic antibiotics after the procedure. So this was a randomized clinical trial looking at non-inferiority, and they did not reach non-inferiority comparing Bulkamid to TBT slings. However, of note, the median satisfaction was very high, 90% or higher in both groups, and complications were much lower in the PHAG group as well. So this is a study that we'll be presenting at SUFU from our group, and this looks at our trends of urethral bulking agent usage compared to sling usage now from 2020, now that we have this product available. And so, historically, we didn't use urethral bulking agents as much. It used to be like a third was the kind of counseling that I gave. A third improve a little bit, a third don't improve at all, and a third are cured. But now we see much better improvement with 80% with Bulkamid. So in particular, I think the role for Bulkamid is really crucial for occult SUI in patients that have concomitant prolapse. So occult SUI is when you do not have any leakage or stress urinary incontinence pre-op, but you have a kinked urethra. And then we test patients with urodynamics to assess if they are going to develop stress urinary incontinence after the urethra is unkinked. So I think that we want to avoid any additional mesh-related complications. So I think that there's a huge role for urethral bulking agent in those patients. That being said, slings are still our gold standard, and pubovaginal slings, or autologous slings, have been around for many years. Allograft slings are also an option, and the midurethral sling is what we'll concentrate on as well. So autologous fascial slings have been around since 1933. And the success rate depends on the definition. Again, we're dealing with benign urology, not cancer. So success rates, we don't have a true definition of success, unfortunately, within our literature. But compared to birch culpable suspension, which is not really used anymore, there's much higher success and lower risk of complication. So these are the two options: rectus fascia or fascia lata. So over on the left, we perform a fan and steel incision 2 centimeters above the pubic symphysis. We harvest 8 by 2 centimeters usually fascia. There is increased morbidity and increased pain postoperatively because of the nature of the incision. And we can use a steamy needle to pass this retropubically. I actually use not a steamy needle. I just use my reusable Caldera top-bottom trocar for this procedure. The other option, you can harvest fascia lata from tensor fascia lata from the lateral thigh. The benefit is that you don't have to close fascia here, but you do have to reposition the patient and re-prep. So the role for autologous fascial slings is really in patients that do not want mesh. However, there is bulking now available. For patients with recurrent SUI, I max out at 2 mesh slings and then move on to autologous. Patients that have had mesh complications from slings, erosions into the bladder or the urethra, any concomitant surgeries, particularly urethral diverticulectomy, I sometimes choose to stage patients rather than perform concomitant anti-incontinence procedures. However, chronic pelvic pain, if you want to avoid mesh in those patients, prior radiation is a soft call. I actually do place mesh in most times in the patient, depending on the nature of their tissue. And neurogenic bladder, or patients that perform CIC, because postoperatively it is a higher risk of having to go into retention for a longer period of time and performing CIC after fascial slings. Other grafts that are used besides mesh are cadaveric tissue, which comes from dura mater, dermis, or fascia lata, xenografts, porcine small intestine, mucosa, or porcine dermis. There's lots of products on the market. And the reason why these were brought in as an option is that the idea is that synthetic slings induce a fibroblast response or scar tissue. And sometimes, it's porous mesh. However, it's non-degradable, and biologic graft, in vitro studies show that constructive remodeling. So cells infiltrate and mimic the innate tissue architecture and integrate themselves into that tissue and are there long term. When we are comparing autologous fascial slings, however, compared to cadaveric fascia, this is a small study, retrospective study up to 12 months. However, really did not show really a true benefit from the cadaveric group compared to autologous. So autologous is still superior. However, it's a less morbid procedure to offer cadaveric options, and there are more studies out there. It's very variable with outcomes. Synthetic midurethral slings, again, are polypropylene porous mesh, are permanent. We place them tension-free, very important. It's an ambulatory surgery, which lasts about 30 minutes. Stitches in the vagina, those stitches melt away in 6 weeks when I talk to patients what to expect. And there's many ways to approach this, the retropubic or the transobturator, and we do have long-term data available. So I'm going to concentrate on this data from Scandinavia, and this is really what I quote to my patients when I'm counseling them about the different options. So this group looked at first 131 women. They looked at their bottom-up retropubic sling, and at 12 months, so short-term, their outcomes were 91% cure rate. I mean, that's the beauty of stress urinary incontinence. I'll talk about my OAB component a little bit later, but we can cure patients with a procedure, for stress incontinence. So 91% cure rate, 97% significantly improved, minimal complications. Same group, looking at the same exact patients at 11 years. So then they showed that 77% of patients consider themselves to be improved. 95% had negative cough stress tests on exam. Really astounding, this group had 17-year follow-up. For this same exact patient population, we can't really replicate this in the US, it's too hard, but Europe is able to do this. And they showed on exam that 90% of women had negative cough stress test, and 87% were subjectively cured or improved by questionnaire. So when I talk to patients, I talk about the durability of slings, and I think that's really crucial compared to, for instance, the urethral bulking agent. Transobturator slings came out in 2001. So again, they have different approaches. They were really developed to avoid major bowel, vascular, nerve, or bladder complications in the retropubic space. But this is the hallmark study that we always talk about in our journal clubs with residents and as trainees. And it's really looking at the complication risk. It shows that success rate is very comparable between transobturator and retropubic. Voiding dysfunction is a little bit higher, still low, but a little bit higher in retropubic group. And bladder perforation is a little bit higher in the retropubic group as well. You're trying to scrape the pubic symphysis and avoid getting into the dome of the bladder. Vaginal perforation is rightfully so a little bit higher in the transobturator group, but the vaginal sulcus is variable. The depth of that is variable between patients. And the crux of the study looks at the rate of neurologic symptoms. So weakness in upper leg, groin numbness was much higher, 10%, 1 out of 10 in transobturator group. So overall, there was no difference in subjective success between slings, but the difference in complications. And so the take-home message that I get from this study is that urologists and urogynecologists can deal with bladder perforations. They can deal with voiding dysfunction. We got that kind of complication. But it's very difficult to treat and to make patients happy for a quality of life surgery with neurologic postoperative complications. So that's what we like to avoid. Single-incision slings were first introduced in 2006, and this was to minimize postoperative pain from the transobturator sling in a more minimally invasive approach. So they say that this can be done under local anesthesia. I don't know anyone that does this, but it is faster. Some urologists don't even perform cystoscopy to look at ureteral jets afterwards. But this Cochrane review actually is newer. It's from 2023. So I want to highlight this because we excluded TVT Secure, which was taken off the market. That was a terrible sling. And now we use Caldera Altis most of the time. And looking at autologous sling, there was one study, but looking at retropubic, comparatively little to no difference in subjective cure or improvement of incontinence. And looking at a Transobturator, I mean, this is what we want to compare, right? So similar cure or improvement at 12 months. Don't really have long-term data, that's the problem. And likely fewer cases of postoperative pain at 24 months. So single incision slings are as likely as mid-urethral slings to cure incontinence and may be associated with less pain, limited follow-up compared to our robust retropubic slings. I really, for me personally, I don't see much of a role. If I'm going to put a mesh sling in, I'm going to put a mesh sling in, unless I have like a patient with a kidney transplant that I want to avoid the retropubic space. Experimental treatments are things that are kind of coming off the press, or vaginal lasers, stem cell therapy, and radio frequency. So this is a study to look at lasers versus pelvic floor physical therapy. It shows that they're comparable, but lasers are expensive. So, I mean, I talk to patients, I'm like, well, you can go and have the Mona Lisa, but it's costly. So compared to formalized pelvic floor physical therapy. Yuga came out with an opinion piece showing that, just stating that there's no robust randomized controlled clinical trials to look at long-term follow-up of laser treatment. So they really don't condone, we don't condone it in our guidelines right now as well. Stem cell therapy has been brought up by the Cook myocyte trial. And this is autologous muscle-derived stems or progenitor cells that are cultured in vitro, injected into the urethral sphincter. It's like a bulking agent, but it's not a gel or a product that you're putting in to your body. It's for your own natural tissue. The downside is that it takes approximately 12 weeks for this to kind of grow in a lab. So a muscle biopsy is done, and then 12 weeks later you have to tell a patient, oh, you have to live with their symptoms for this amount of time, and then we'll go ahead and inject it. The other thing is the studies have not shown great success. So interim analysis showed a 90% response rate of placebo during enrollment. So recruitment was halted in their hallmark study. So the verdict is still out for this product. So in summary, I think it's important to emphasize shared decision-making when talking to patients about treatment options for stress urinary incontinence. Of course, always think about the degree of bother for guiding treatment and really their goals. Do they want to be dry, or do they just want to get back to their normal activities right away? And obviously important to talk about the unique complications that are associated with each. PHEG is a new and safe bulking agent with much longer-term success compared to the old products that we've had out there. And so synthetic midurethral slings are still the gold standard. We do have long-term data to show that patients are dry long-term. And there's similar success between retropubic and Transobturator, but different neurologic symptoms. And the role for single incision slings are appealing. It's a much faster procedure for a sling, but there's short-term success. And we really need more studies to look at other things. So thank you.